Olivia Stewart. I am an RN at Raleigh General in the SICU. I've been there since last year, about the beginning of June. I'm going to talk to you today on an ethical problem. And I'm sure this is every nursing home, every hospital around. Should artificial hydration and nutrition be used in end-of-life care? I think I chose this topic because I see it a lot in the ICU. I see decisions trying to be made and even disagreements between family members, between family and nurses, between family and physicians, and even nurses and physicians. There's a lot of differences that people don't even know about, like the differences between short-term feeding tubes and long-term feeding tubes. It makes you think, what if it were my family? What if it were me? Would I want this? Would I want to live like this? Is this the type of quality of life I would like to have? Is it justified? Is it ever justified in a situation, or is it never justified? Dr. Robert Arnold from University of Pittsburgh said, "No subject provokes greater distress and uncertainty among both families and health professionals than issues surrounding the use of artificial nutrition and hydration in the dying person." And I believe this to be true. Three simple questions I'm going to answer real quick are who, why, and what. Who do we place feeding tubes in? We place them in mechanically ventilated patients. We place them in patients with a tracheostomy, and most of the time you do hear people having a trach and a peg. They almost go hand in hand together. Stroke patients, patients that have problems with dysphagia. Why? Obviously, they have an issue to where maybe they can't absorb food, maybe the stomach has had a type of surgery on it, and they just are malnourished. Bottom line is they need nutrition. What? So there's a couple different feeding tubes. There are NG tubes. Us as nurses place them. They're short term. We usually expect less than 6 weeks, and even if it's 6 weeks, we need to be replacing these, maybe changing to the other nostril, or you can also do oral gastric tubes, which go down the mouth through the throat. We check placement on these every 4 hours. We check placement on all feeding tubes every 4 hours. And these are usually tubes that we expect patients to be able to gain that oral intake back, to be able to use their mouth and absorb their food. There's also NJ tubes, which are the nasal jugostomy tubes. They're also short term. They bypass the stomach, and these are usually for post-op patients. We don't see those as much. Then there is the jugostomy tube. That is a long-term tube. It bypasses the stomach. It goes into the small intestine. Your GI tract is compromised, okay? You usually are under general anesthesia whenever they place these, so it's a little more invasive. There's a gastrostomy tube, which we see very often. It's the most common long-term tube. It's a PEG tube, and this stands for percutaneous endoscopic gastrostomy. Then last, which we don't see as much and it's also more short-term, is TPN. It's total parenteral nutrition. You get that through a central vein. We do these in our central lines through a catheter, and it just has all our nutrients that we need. There's pros and cons just to even short-term and long-term feeding tubes before we even ever decide, do we want one or do we not want one. So these pros to the ones that insert into your stomach, the pros to that is it's more natural option. The stomach is a reservoir for the food, so that's a natural option. It's less likely to have dumping syndrome. They tolerate intermittent feedings better than they do continuous or bolus. And your stomach has hydrochloric acid, which helps fight infection. The cons to these that go straight into your stomach are usually they're only short term, and it's uncomfortable. If you had something in your nose, feeling like it was constantly being pulled on. And it's difficult to place sometimes for nurses. We have problems placing them because if someone's had trauma to their nose, we have issues with it coiling in their mouth, or if there's trachea damage. And we confirm these with we auscultate to confirm these. However, sometimes it's hard to confirm them, and we even have to get an x-ray. Then the pros to the ones that go into the small intestine, they bypass the stomach. This is a less risk of aspiration, and it's more comfortable for a patient. The cons is obviously you'll be more prone to skin breakdown, and you do not have the hydrochloric acid, which helps fight infection, so you're more prone to that also. So some cons to getting a feeding tube. There's quite a few of health risks. One is local wound infections. Obviously, when you make a break in the skin or a surgical incision, bacteria can get in there and you're more prone to infection. Painful insertion sites, same thing. If you make a break in the skin, it's usually going to be painful for a little while. Inflammation of the stomach lining and hemorrhaging. You can aspirate, which leads to the aspiration pneumonia, and you're actually 3 times more likely to aspirate with a feeding tube than if you were feeding yourself. Edema is a big risk with these. You're getting more fluid, and that just causes you to swell more, which could also lead to more skin breakdown. Another thing that I'd like to talk about is, you don't really think about this, but nursing home patients especially, you get your demented patients, your Alzheimer's, just confused patients, and what are they going to do? They're going to pull out their IVs, they're going to pull out their oxygen, they're going to pull out their feeding tubes. So you have to end up restraining these patients, which can also lead to skin breakdown again. A lot of times people have their opinions like you're starving them, you're giving up on that person. The correct term that everyone actually needs to use is dehydration. They will be harmed from dehydration. However, patients will normally die from a chronic illness way faster than they would from just being dehydrated. It also shifts the attention of the caregiver to the equipment more than that one-on-one time with the patient, not having to feed the patient and engage in them and talk to them. Going back to the edema, too much fluid can also cause like abdominal problems, nausea and vomiting, and they have a lot of issues with diarrhea, which could end up leading to a rectal tube, which also causes skin breakdown. Pulmonary edema. Before we go on to the pros, I just want to add, we talk about dehydration like it's a bad thing. However, we can look at it in a good aspect too. If you're dehydrated, you're making less urine, which also means that you don't need a catheter, and you also are not more prone to UTIs. It decreases pulmonary secretions when you're dehydrated. You decrease swelling, you reduce that nausea, vomiting, and abdominal pain, and your diarrhea. So there's those things to look at too. Pros of the tube feedings, obviously the first one is you're going to be nourished and you're going to be hydrated. That's the obvious reasons we put these in. It's very beneficial to stroke patients. There's been many cases where a stroke patient will have a PEG tube or such for a year and then come back, have it removed, and they've gained all that strength back and can eat again. So those are really good stories to hear. You're less fatigued. They can conserve more energy. Feeding times are actually reduced whenever you have a feeding tube. You can maintain your weight, obviously, and it decreases choking, chewing, and swallowing problems. There actually was a man that he lived alone, and he loved his PEG tube because he didn't have to go out and buy groceries, he said, and he didn't have to wash dishes and pans, and he lived by himself, and he was fine with that. So some people are satisfied and okay with getting feeding tubes. The current status, I feel like, in hospitals today, feeding tubes can obviously be beneficial or they cannot be beneficial, but it's been proven that artificial nutrition and hydration for patients at end-of-life care rarely restores nutritional status nor prolongs life. So there's that gray area that we toss and turn, the idea of will they benefit or will they not. And as nurses, we have to follow the 5 ethical principles. Beneficence is doing good, acting in the best interest for the patient. So if you see that they will have a good outcome, if an NPOA or the patient will be making their own decisions, but if there's a good outcome, then you would want to do it for the patient. If there's a bad, you obviously wouldn't. If there's that gray area and you're unsure if they would benefit or not, a lot of people say make a time frame, let them have the feeding tube. If you see benefits, keep it. If you don't, let go of it. Non-maleficence is no harm to the patient. That kind of goes hand in hand. You know, you don't want to do anything that's going to do harm to the patient. Autonomy. Patients can make their own decisions. If they cannot, an MPOA is there. Either way, the patient has the right to be informed, or the MPOA, of all the consequences, outcomes. You need to be truthful, and they have the right to their own decisions. We try to talk to the patient and let them understand, but they have the last say. Justice is just simply being fair. And virtue is trust, like protecting, empathy for the patient, honesty. So at the end of the day, no matter what, it's very important that your values do not get in the way of these patients' decisions. Sometimes you have to agree to disagree. Lastly, I just think that this problem is causing a lot of disagreements in the hospitals, a lot of problems. We actually had a patient that he was a trauma, and he came in from a car wreck. He ended up eventually being ventilated for 14 days, and then he got the tracheostomy and a PEG tube. His wife was his MPOA. The patient had a lot of mental issues that we didn't quite understand because all of his tests came back great. We just couldn't find anything. A neurologist was on the case. Nothing was abnormal. But he wouldn't follow commands. He would be restless and anxious and agitated. And his wife finally told us one day, she said, "I think he's mad at all of us because he did not want this." So she made the decision for him. However, she knew that he didn't want this. So it's causing a lot of burdens and disagreements and situations that we shouldn't have to put people through. It's a caregiver burden. Also, a lot of people are having to burden. They can't handle all the stress of feeding tubes and, you know, all these different things and scenarios. And the last thing, it can cause longer hospital stays. And that's probably the least of our worries to us as nurses, but that is also a problem. I actually printed out some pictures of a lady with a TPN. It shows the bag. It actually looks like she has some lipids hanging also, and it shows her central line, and it shows that it's going to your heart. A simple nasogastric tube, and this is the same thing as an oral tube would be, other than it's in your mouth. This one is actually a PEG tube. It's just inserted in her stomach. They have a clean, dry dressing around it. And then the last is a jejunostomy tube, and as you can see, it's placed a little bit higher because it bypasses the stomach. So that's all I have for you today.